So apologies from Anna Bradley, and welcome to Kieran Walsh. Professor Walsh, who looks far too young to be a professor, is joining us. And I think we're going to pick you up on the strategy session if we can, Kieran. So if you could bear with us for the first sort of hour or so. Is that all right? Excellent. Well, this is my first meeting, so welcome everybody welcome to everyone who's here. And welcome to myself, yes. Well, before we go to David's Chief Executive report, today is the day after the Francis report yesterday, and what happened at Mid Staffordshire is obviously very much in everyone's minds, and I think will determine a lot of what you're going to say in your report, David. I think there were 290 recommendations in that report. Clearly, we're going to have to consider them. I think 100 of them referred to CQC. So I think rather than spend a lot of time on the Mid-Stash report today, we will come back to it in a considered way at our next board meeting when we've had a chance to digest all those recommendations. But it is unquestionably a seminal moment in the history of the National Health Service, and all of us who are in the NHS have an obligation to restore public trust and to ensure that what happened at Mid-Stash never ever happens again. So, David, your report, please.
Okay. Thank you, David. And if I, perhaps there is a paragraph in there about Mid Staffordshire and the Public Inquiry Report. So if I update that Chair as well as presenting the report. So if I begin with Mid Staffs. So Robert Francis published his report yesterday, 3 volumes and an executive summary, 1,800 pages, 290 recommendations. So just to emphasise David's point, this will need reflection and consideration to do justice to the thoughtfulness of the report and the recommendations that he's brought forward. His conclusions were that there was a requirement for a fundamental culture change in the NHS, which puts people who use services, patients first, and his view was that that could be implemented within the system that has now been created. I think a key theme has really been about cohesion and culture across the system, and he said that that won't be brought about by further top-down pronouncements. So his recommendations, and as I say, there are 290 of them, cover a number of different areas. Firstly, putting people who use services first, putting patients first. Is called for the development of what he referred to as fundamental standards, and that obviously has a direct implication for ourselves. But he wants it to be professionally endorsed and evidence-based compliance against the standards. He emphasises openness, transparency and candour throughout the system. He wants CQC as the regulator to police those standards. He wants to ensure that everyone who provides care, individuals and organisations, are accountable. There's a range of recommendations about fit and proper people, declarations by directors, etc. to support that. He calls for changes to the recruitment, training and education and support, particularly of nurses, and makes some detailed recommendations. And also calls for continuous improvement of measuring, understanding performance of individuals, teams and organisations. So a big theme around accountability. On managers, he suggests 2 options, a regulation and a code of conduct where non-compliance with a code results in disqualification, again on the accountability, and says that further work needs to be done to take this and others forward. In relation to, I'll not go through all the recommendations, David, they're there to be considered, and I think it's important to bring back to the board a report which looks at all the recommendations as they relate to us, and that we encourage our staff between now and when we bring that back for a broad discussion of its content and the issues that are raised in there. He calls for all recommendations and individuals to reflect on the report and his recommendations. And the PM yesterday, in his statement to Parliament, talked about studying every one of the recommendations, and then went on to say that the government will respond in detail next month. So there's a sense where I think Parliament concludes its session on that third week in March, and therefore I think one can anticipate a statement to Parliament in relation to the recommendations.
Just to interject, when is the next board meeting, Alessa?
It's on the 20th of March.
Well, I think we need to have paper from you to the board, before that, well before the 20th of March, about summarising, the recommendations, how they affect CQC, and what our response is. That's okay.
Yeah. I've commissioned a note. A note will be sent from my office this morning, effectively asking to do that, and how we reconcile that with a later item on the agenda, David, the business plan, and how we can bring those together, so we know where we are from the beginning of the financial year, what we'll do immediately, what we'll do during the year, and get a sense of the priorities and the timetable for that. So that will be something that we'll be able to bring forward. Francis also says that each board should study and take control of accounting for the progress against the recommendations, but also is very clear that the Health Select Committee, who I think will discuss Francis's report with him on Monday of next week, should also be put in the position of regularly reviewing the progress made by organisations. We already have an annual accountability meeting with the Health Select Committee, so one can anticipate that that will probably be the vehicle through which this will be taken forward. Francis, I think, attempted to have a very balanced report, and he said he wanted to look at how the system had failed people, and that he didn't want to raise the issues of, I think he used the word witch hunt in some of his interviews yesterday, around how individuals may or may not have performed. And so he was, I think, striking a balance. But he was absolutely unambiguously clear about the failure of the whole system and the unacceptable treatment that people received in Mid Staffordshire. He did comment on organisations by going through the history of it, and I think there's detail in there. One of the issues he's raised with the Healthcare Commission previously is the time it took the Healthcare Commission to identify the issues at Mid-Staffs, whilst congratulating the inspection that they did for actually identifying the issues. So there are messages, I think, from our predecessor organisations which we need to digest. He also raises the issue about the openness of our culture, and again, we need to digest those recommendations as we move forward.
Just on that, I mean, people do interject if they want to, don't. I mean, one of the key messages, which you just alluded to, was the amount of time. The Health Commission may have got onto the case and diagnosed it properly, but this was a lot. It took too long.
Yes. I think one of the issues here is urgency. Where there is risk is about the urgency with which organisations both share information and then respond. And therefore, I think it's a powerful message that we need to include as we bring forward how we're going to respond to these, David, how we're going to respond with that urgency. I think challenges moving forward are how we continue to reflect that urgency in our current work as well as in the future planning work that we
and I sort of feel, I don't know how other people on the board feel, is that, we can raise questions before we know the answers. I mean, if we're waiting until we know the answers, it'll take too long.
Yes.
But actually, we need to have a series of measures, we'll come to this later on, which at least raise the question.
Yes.
And put people on notice.
Yes.
And then we can share those questions with Monitor and others. Yeah.
Quite so. So in terms of what did Francis himself emphasise, I thought his presentation to the press conference was simple and powerful, and he raised 5 issues that are required. Firstly, a structure of clearly understood fundamental standards and measures of compliance accepted and embraced by the public and healthcare professionals with a rigorous and clear means of enforcement. Much of that is directed at CQC and presents a real opportunity for CQC in terms of its position in the system and moving forward.
On that, in terms of the difference you think between fundamental standards and essential standards and minimum standards and acceptable standards and good standards, I mean, where do you think, is there a meaning attached to fundamental that we ought to?
I think there is, David, but I think this needs defining and inventing as well. But he's clearly saying there is a difference between a fundamental standard, which he says a regulator is responsible for, and standards which go beyond the fundamental, for which he says it's commissioners that are responsible for. This has been an issue that I think has been around for probably well over a decade, and I think his recommendations bring pretty unambiguous clarity to the role of the regulator focusing on what those fundamental standards are. And I think by raising the issue fundamentally, he breaks through I think something that Kieran raises in his report, and this may come out later, about minimum, maximal and median standards, and actually says, but the key issue I think he raises is these standards have got to be meaningful for people using services, and I think that's a challenge to our current methodology about how far we're looking at standards which are meaningful to patients. But he also says that they've got to be embraced by healthcare professionals. They've got to be an evidence base about what sits behind them as well. So I think in a very helpful way, in my view, he's actually broken through a debate which has gone on for a number of years and said, let's reset the debate about standards, and we should class them as fundamental, and they should be relevant and meaningful to professionals and people who use services.
Kieran, do you want to sort of add anything to that on fundamental standards?
Thanks, Alison. I think the question you might ask is whether the standard being fundamental means that it is a fundamental issue that any regulator or commissioner should concern themselves with, or whether you interpret fundamental as a base level of performance to which every provider should reach. I think there are those two interpretations there. So you might have a fundamental standards to do with, for example, dignity and compassion in the delivery of care, against which you assess organisations, and within that, some provisions which are clearly essential and any provider must be able to deliver, and yet still some scope for organisations to reach beyond that. And that, I think, is the point David was making about having maximal standards which provide some scope for improvement.
Steve?
I think that's helpful, but I also think Francis is saying something a bit more than that. We've got 16 standards. Is he not suggesting that 16 fundamentals is possibly too many, and that if we want everyone in the general public to understand what those standards are, we shall have to have there'll have to be fewer standards, clearer and more readily digestible by the general public?
Yeah, I think that is a very good point, and we have discussed this. That actually the standards that Lord Darcy came up with in 5 years ago, whenever it was, effectiveness, experience, and safety. I think are the three standards, and then maybe the fourth standard is this whole area around culture and leadership, clinical engagement, and I think those are the four. We would group our fundamental standards around those four domains. But I think we're going to work very closely with NICE and others on this, aren't we? Because, I mean, NICE have been given quite an important role. Well, Francis suggests that NICE should have a pretty important role in the methodology behind those standards.
So I think if I've absorbed the detail in Francis on this point, I think what he's saying is that the work should go on between the department and themselves in relation to the fundamental standards. The commissioning board are obviously going to have a role in relation to those standards which go beyond fundamental. As you've said, David, I think the domains of quality are really around effectiveness, efficiency and safety, and we need to think about how they map on. And then NICE, as I read Francis, if I do justice to it, is talking about the tools and methodologies that are used. So I think they're the key organisations which are highlighted by Francis's recommendation, where over this next period we need to have the discussions with them about how we develop his recommendations and take them forward. So there'll be a sequence of bilateral relationships that we'll need with organisations and a sequence of multilateral relationships that we'll need to actually begin to take this forward. So I think on your point, David, about bringing a report to the board at the next meeting, we'll bring that by recommendation of where we've got a direct recommendation made to us, and we'll also look at recommendations which are made to other organisations which have an implication for us, and begin to set out how we might respond to those and take it forward. And the intervening period will allow us to have these debates. It's a challenge, I think, to respond immediately to every recommendation that Francis has said, and I think what he's calling for is let's have the discussions within our organisations and across our organisations so we can settle these, and I think he's right on this.
But just one last point on that. Again, it comes out of the Francis report, but it is, I think, obvious, is that, I mean, what he's not saying is he wants hundreds of more inspectors going around ticking boxes or with checklists. I mean, he is saying we need to exercise judgment. And I think it is that exercise of judgment, particularly around the culture of the organisation, which is incredibly important. Which is not to say that we don't need inspectors going around hospitals, but it is that sort of senior level judgment. Is this a good hospital? Is there really strong clinical engagement in this hospital? Because in a way, I suppose if you're taking a broader view of what's happened, the level of doctor and senior nurse engagement in hospitals is so important. And, if we're honest, many doctors, many nurses have been turned off over the last few years. And I think it's getting that culture back into the NHS where there's a real partnership between the management and the clinicians that is, really at the heart of a good hospital.
I think, it's within the board, I think when we're sort of considering various issues, I think it's really good for us to have kind of debate and exchange of views. So I'm looking forward to having that debate and exchange of views. On the Francis report, I think that what we mustn't forget is that if patients had been listened to much earlier, we probably could have intervened earlier, we could have reacted earlier, and we could have actually prevented a lot of the harm. And I would actually like to pay tribute to Julie Bailey and Cure the NHS, because they didn't go away. They weren't listened to. In fact, it was the opposite in some cases. They were seen as troublemakers. So I think that it's really important to realise that if we had listened, things could have been different. And it is thanks to Julie Bailey and Cure the NHS that we're now in this position, which I see as a sort of positive one going forward, because we have at last got acknowledgement of the issues. On the culture issue, there's been a lot of sort of discussion around culture in recent months, and I hope very much as an organisation we will get to grips with that, not just in services, but in our organisation as well, because I think we do have a responsibility to lead by example. And finally, I think, as you said, a lot of the recommendations do relate directly to CQC. So there's some real kind of opportunities there for us. I hope we will step up to the mark, but we mustn't underestimate the transformation that's needed. And we need to be realistic as well. Okay, thank you.
We'll come later on in the meeting to the changes in CQC that are required, if you like, to deliver the strategy that we'll also discuss later on. So thanks very much. Okay. David?
Okay, thanks, David. So the second change that Francis emphasised at his conference was about developing openness, transparency and candour throughout the system. And he makes a number of recommendations in this respect about the declarations that directors of trust should make in relation to quality statements, for instance, and goes on in some detail about installing a responsibility on people that work in the system. The third area he identified was about the development of compassionate, caring and committed nursing. A number of recommendations in there about nurse training, nurse development. Also raises issues in relation to the regulation of healthcare assistants and how nurses are to be developed moving forward. The fourth area is about the development of strong patient-centred healthcare leadership. And again, recommendations for the development of leaders across the healthcare system with that focus on people who are using services. And then fifthly, an emphasis on the accurate and useful and relevant information, both to people using services, but also between services, which I think pick up on some of the comments made earlier. today. I personally found it very helpful to actually think about those 5 areas in sifting through the 290 recommendations and a way of just corralling those into something which helped me personally to access the report. Again, to emphasise that Francis was saying, please take this away, please debate this openly in your organisations, at your boards, bring forward how you intend to respond, and we've talked about that. The Prime Minister then followed Francis by giving a statement to the House at 12:30 yesterday afternoon. Hugely significant in my view that the Prime Minister chose to make that statement himself. And the Prime Minister was very careful to express his apology to the people who had used services in Mid-Staffs and the people of Mid-Staffordshire who had been failed. He went on to say that the government's priority was to evaluate all of the recommendations that were made. And what he did say is that there were 3 overriding themes which will be tackled immediately around improving patient care, increased accountability, and the phrase that he used is defeating institutional complacency. He mentioned in quite a long speech the creation of a single failure regime where a board of a hospital could be suspended for failures relating to quality in much the same way they can currently now be suspended for failures relating to finance. He also reinforces previous commitment about a family and friends test and people being given the opportunity to say whether they would recommend a service to their family or friends. These should be published. Nurse pay should be linked to the quality of care. The GMC and the Nursing and Midwifery Councils have been invited to explain what steps they have taken to strengthen accountability, coming back to one of Francis's themes for professional decision making. The government will consider transferring the right to conduct criminal prosecutions from the Health and Safety Executive. This was one of the issues debated in the evidence to Francis, and Francis made recommendations on this to the Care Quality Commission. And he also announced, and this has a direct implication for us, the creation of a Chief Inspector post within the Care Quality Commission, and that post will be responsible for overseeing the hospital inspection regime. The debate that then followed really was about both what Francis himself had said and about what the Prime Minister had said in terms of those urgent actions and activities. We briefed staff yesterday, Chair, in relation to what the high-level messages were. We'll use the next 2 days or so to get messages out to our staff about what the implications are. I think one of the issues that's probably worth drawing out that we got questioned about yesterday was the proposition in Francis that there should be a single regulator where some of the functions that are currently sitting with Monitor should actually be brought into CQC. I think we need to consider that and have discussions with Monitor. The most important thing is that we work well and effectively with Monitor. We've been doing that to date on a number of issues. Some of the work we've been doing in relation to Basildon, for instance, I would quote as an example of how we can work together. So there are some important issues for us to consider. I think the most significant, though, Chair, is that a lot of what Francis said about moving towards specialism and developing inspectors who will focus specifically on particular areas like healthcare, like social care, is something that is consistent with our strategy. So I think there's much in Francis which supports and reinforces the direction we've been setting out in our strategy. So I think there's good momentum for that. There's also some things which are different and new to what we set out in our strategy, and they need to be accommodated as we move forward. So if I pause on that, I think that's as much as I'd want to say on Francis, David, and there are other items in the report which I'm happy to present.
Does anyone else want to add anything to what David and others have said on Francis, or shall we wait and have a more detailed debate about it when we've got all the recommendations? Okay,
Yeah, I mean, Anna's not here, but I think it would be worth considering a separate response from Health Watch because I know Health Watch was mentioned a number of times, so it's just, that might be sort of helpful. It might happen anyway, but I think it would be a good thing to do.
That's a good point. Okay, well, we'll pick that up at the next meeting. Okay, thank you.
There's obviously, the Francis report has taken quite some time to get to where we are now. I think that the public and Parliament will be very impatient for action now. There's sort of momentum behind it. And that will put a bit of artificial pressure on us to respond very, very rapidly. I'm just concerned that we give ourselves enough time to make the right decisions, because and we've got to get that balance right. And I think, you know, we will have to work quite hard and get good advice and think these things through under a pressure of a constrained timetable that we should need to be careful about.
Yeah, I mean, that's good advice.
I agree with that, David. I think that the report that David Bean mentioned earlier on, the analysis, being circulated to the board in good time so that we can read it, reflect on it, reread the report itself, and then have a proper debate, I think is the right way to go about it.
Okay, well, thank you for that. So I've asked David to do for the board, and that is to do, using all the information we have in our intelligence unit and elsewhere, and information from Health Watch and outside, is that we should identify this sort of 10 to 20% of hospitals that we have the most worries about. That's not to say that those hospitals, anything terrible is happening in those hospitals, just that there are smoke alarms going off in those hospitals, and we need to have a close eye on them. And I think the board needs to know, A, that we have that list of hospitals, and B, what we are doing about it, and who else we've involved in worrying about them, if you like, whether it's Monitor or the TDA or whomever. And I think that is a priority, because we can't take our eye off the existing ball while we are refocusing the business and restructuring the business to take it forward. Okay.
And just to confirm, Chair, that we'll take that at speed and ensure that board members are absolutely clear about what those areas where we're currently engaged with Monitor, the TDA, or if we're unilaterally engaged, where we're unilaterally engaged with those organisations. So we'll collect that and draw that together quickly.
And just to add, David, that quite rightly the focus is at the moment on hospitals after the mid-staffs, but social care is also remains a priority, so we mustn't take our eye off that ball either.
I completely agree, and I think we've had conversations during yesterday and today about exactly that issue, Chair, and I think your comments yesterday about an equivalence of a Chief Inspector of Social Care is a helpful statement of the priority to be afforded to that, and I think the risk afforded to some individuals that are in some care homes that are not meeting standards is real and significant, and whilst that hasn't really received the publicity over the past few days, nevertheless is something that we need to focus on, so we'll continue to do that. And that probably bridges nicely to the rest of the report, really. What we've done what I've done in this report is just draw attention to an update to the inspection programme. You do have a report later in the agenda which goes into more detail about this, but this has been a big issue for the board, which has received senior attention over the period, over the past 6 months or so, and a lot of debate here. So what this report is doing is just drawing out our current progress in relation to carrying out our inspection programme for this year. You'll see improvements have been made. We've completed, as at the 27th of January, 20,923 inspections against our programme. There's more than 8,000 inspections remaining over this next period, and we set out there the progress across the different regions. Last week, one of the teams in the north completed their programme, and so that progress is being made, and I've expressed thanks to the team that have actually managed to get through their programme and completed it. There's still a lot to do, and we've talked previously about the risk, and there's a more detailed report later in the agenda. The strategy consultation has now concluded. We've done an analysis of all the feedback, and we've begun to set our priorities for action next year. It is important to stress a lot of the feedback that we got from stakeholders and from our staff in relation to the strategy is reinforced and supported by what Francis said. There is a consistency and a coherence with a lot of what Francis has said, and one of the jobs that we will now do is begin to draw together what the Francis recommendations mean for our planning for next year and how we allocate time and resource, that's physical resource as well as financial resource, to those activities. We've got Kieran's report later and the Deloitte's report later, which also need to be incorporated into our development. And then finally we get in March the results of the Nuffield Trust report on aggregated assessments, and with that we'll finally be able to set the plan for next year and bring back the detailed proposals. I'm not proposing, Chair, to run different action plans on each of those 4 changes. We want a single unified business plan for the organisation for next year, which shows how we'll take forward the work that is in front of us, balancing, as Steve Hitchens has said, the day job, if you wish, the current activity with the changes that we need to make, and we'll bring forward proposals about how we can take that forward and resource that moving forward over the next few weeks.
I think it's fair to say, isn't it, that the coming together of the strategic review, the Francis report, Kieran's report, the Nuffield Trust, they're all pointing in the same direction. You know, so that I think the direction of travel, if not the detail, is very clear.
That's absolutely the case, and the interesting reflection from some emails that I've received for staff over the past 48 hours is the emails that have been sent to me are fully supportive of the direction of travel that are laid out as well. So I think it's harnessing that energy that we've got from people outside the organisation and inside the organisation as a platform for moving forward. So very, very positive and helpful, as well as challenging. I'll not say more about aggregate assessments, Deloitte's and Kieran's work. I draw attention to the update on the Grant Thornton review. That work continues. Grant Thornton are carrying out the additional work which picks up on an individual complaint alongside the previous complaint that they were investigating. They're still on track to deliver a final report by the end of February. And again, that will be something that we need to consider. A really important report, which has probably received less publicity than perhaps it should have done, but certainly relates to Francis's recommendations about complaints. Francis asked Anne Clwyd and the Chief Executive of Tees Valley Hospital to actually do some further work on complaints. Anne Clwyd, because of the publicity surrounding her complaint about her husband's care, is a very apposite choice. But Baroness Fritchie was asked by the Parliamentary and Health Service Ombudsman to undertake a review of a sample of cases they've been considering, and that report has now been published. There are a number of recommendations that Baroness Fritchie makes to the Parliamentary and Health Ombudsman which have been accepted, and they will have implications for us. We've got a mature relationship with the Parliamentary and Health Ombudsman. Louise leads that relationship on our behalf. We have a memorandum of understanding, and I think an effective working relationship with the PHSO, which will allow us to consider that. I think the debate about complaints, while not directly to from Francis directly to CQC, has profound implications for the way that we operate. I think one of the great unresolved issues over the past decade or so is the centre of gravity for resolving complaints, particularly where those complaints relate to people in registered and regulated services. And the vast majority of my correspondence is in people making individual complaints about regulated services. And of course, CQC does not have a power to determine and resolve individual grievances. It is the intelligence we take from this. So work on this area, aligned with the PHSO report, Baroness Fritchie's report, is particularly important.
I think just David, on that, I mean, on complaints, you know, it's often, if you look at the numbers of complaints in a hospital, that can be quite misleading, because often, you know, good hospitals will have a culture which encourages people to make complaints. It's really the way that hospitals deal with complaints, and it's quite hard to get at that. But I mean, learning, I think it will be quite interesting for when we do inspections of hospitals, to look at the paper on complaints that goes to the board every quarter, or it should go every quarter, and see how hospitals have changed their behaviour as a result of complaints, rather than just knocked an individual complaint on the head.
Chair, I absolutely agree with that. I absolutely agree with that. I think the issue, if you ask any organisation, have they got a complaints programme, they will say yes, they have. The issue is, I think the second question then is, and what have you done differently as a result of those complaints? And so I think that goes right to the heart of the culture of organisations, which you've already flagged, Chair, that we need to look at as we move forward. So it's hugely important.
A simple thing. I mean, who signs off the complaint? You know, who reads through the complaint and really goes through it? And if the answer is not the chief executive, you sort of want to know, well, why not? I mean, I'm sure it usually is, but I would hope that it is.
Yeah, I mean, complaints has been a big issue for patients for a long while. And I think it's not simply about complaints. It's about the whole kind of, again, it's the culture about how organisations get ongoing feedback from patients or service users. And it does play directly to one of our essential standards. And I think it would be quite helpful for us to think a bit more about how we get underneath that, you know, not just looking at board papers, but looking at what's in place for monitoring quality, including complaints, and then testing that out with patients or patient groups, staff, for example. Do staff get feedback, you know? It needs to be kind of throughout. The other point is a more general one. It's on these memorandi of understanding. We have a lot of these, I think, and I'm not entirely sure how well they work, because we did, it seems, have one with the Ombudsman, but we're going to strengthen it. And in the new world, we're putting much more emphasis on partnerships, working together in the kind of ethos that we are stronger together. And so it was a kind of general question about these memorandi and whether there's any sort of plans to review them, review how they're done, or either generally or specifically with each organisation that we've got them with, you know, with a view to sort of strengthening the relationships and interdependencies.
Just to confirm, I sign all letters of complaints and they all come across my desk for this organisation, just to remove doubt on that point. On Memorandum of Understanding, Kay, I think are a means to an end, not an end in themselves. They actually set out what the terms of engagement are between the organisations, in a sense. And I think they've been reviewed since over the past 12 months because of the previous challenges about how well we articulated our relationship with the other organisations. I think it's absolutely essential we review those, and Jill's been leading some work on allocating stakeholder leads. We've got a director that leads every one of those relationships. I know that on the Parliamentary and Health Ombudsman one, for instance, we've got a very good relationship with them. It's very open. I feel I've got a very open relationship with the Parliamentary and Health Ombudsman. And I know Louise and our complaints team both have quarterly meetings, but are on regular dialogue in relation to specific cases which cause that to happen. So I think if we went through the organisations, yes, there is always more to do, but I think there's a good baseline structure to those relationships, which is moving well. But the plate tectonics of this, if I can use this, are moving quite considerably. And I think what Francis did yesterday is actually raise a huge number of issues right across all of our primary agencies, which probably made a number of those MOUs redundant on the minute he published. So we'll have to renegotiate our work with the Trust Development Authority, the work we're going to do with the Commissioning Board. And if you go through all the recommendations, I was keeping a running total of all the organisations that we need to come to some understanding with in order to discharge those recommendations. And actually, I think I got about 10 organisations down that we will actively need to do some business with to take forward those recommendations. And they'll all need those relationships redesigning. I think the most important thing is developing relationships of trust and confidence between people, and the documents of MOUs are a means to the end of actually just setting out the terms of engagement. Just
a very quick point that as well as the kind of strategic understanding, we need to make sure that it goes right through down to operational level, because that's where in some ways the important stuff works. So we need to kind of just make sure we can close that circle, if you like.
I was going to say that a part of the strategy, as you know, is the Strategic Partnership Programme. And one of the recommendations in that is that with those who are the very significant bodies that we work with, we come to the board with an annual plan, whereby, so you would see the annual plan that we intend to have with Monitor and how we intend to work. For example, what we're putting in that plan for the 12 to 24 months and what we think success looks like, and Monitor agreed that they would expect that plan also to go to their board. So I think that puts a lot more a weight behind something which is significantly more than an MOU.
Sorry. David, thank you very much for that. John, the performance scorecard, the third quarter.
A standard written report, as well as the detailed scorecard and with all the KPIs. Just a couple of comments to start with. The report itself and the detailed performance scorecard, both fairly detailed documents, and these have evolved really over the course of time as more and more information and the board have requested more and more information as CQC has evolved in the last 2 to 3 years. What we're actually working on now is trying to condense this scorecard into a more robust view of the key performance indicators that reflect the strategic shifts going forward. Our plan is to model it more along the lines of what we've got in the public scorecard at the minute. We're hoping to have that all in place for the April reporting. It will broadly follow the shape of the balanced scorecard, the operational activity, customer service, registration and enforcement activity, and will deal with our resources, both financial and people resources. If I can turn to the performance report, as David said, one of the key things that we've been focusing on recently is the inspection activity. And we do produce a weekly report now on our inspection activity across not only all the sectors but across the regions as well. And the most recent one that David referred to was the 27th of January, where we had completed 20,923 inspections. There's still just over 8,820 inspections to do between the 29th, 27th of January and the year end. Just a point for the board to note, the required run rate in order to hit our target between now and the end of the year is 891 inspections per week. And the week of the 27th of January, we achieved 822 inspections. So there still is a bit of work to do. The focus really is on the south, where there is the biggest shortfall. But if Amanda maybe perhaps wants to comment on this in terms of the updates, it is going to be close. I think the run rate is increasing, but it will be pretty close, and we feel that there's every opportunity to achieve this target.
John, I mean, maybe this is a question directed more at Amanda, but I mean, there's some inspections take much longer than others, don't they? And we don't want to just hit the target and miss the point. I mean, can you assure the board that we're not skewing the inspection schedule in order to hit the target, but not do the inspections we think are the most important?
Thank you, Chair. And we've had, in the last 2 previous board meetings, very helpful discussions and steer from the board about making sure that we don't lose the focus on risk and quality, and also ensure that we maintain the organisational resilience of the inspectors who are working incredibly hard to deliver on our public commitments. So we have communicated through the deputy directors and heads of regional compliance that absolutely risk and quality must be directing the resource of the inspector availability. We're also focusing very, very hard on the quality assurance processes and working very, very hard to target the bank inspector capacity on lower risk on the basis of information inspections to undertake. So we absolutely, it's not about hitting the target for the sake of hitting the target. It's delivering our public commitment to inspect services that have vulnerable people very often receiving services.
I just want to deal with a few other issues in the detailed scorecard without going into a lot of the detail. A few things that the business is monitoring on an ongoing basis, registration activity as well. And at tranche 5, the registration of primary medical care. 7,644 providers have submitted an application to register for primary medical care at the end of quarter 3. Very much on target to hit all providers by the end of March. And over 80% of providers that have submitted an application are now in receipt of a notice of decision. So it's very much on track to hit all of that by the end of the year.
Again, just John, I mean, or Amanda, I mean, if we were to do a survey of the GPs who have registered with us, what would their view be of the registration process?
I would hope.
Sorry.
I would hope it would be as positive feedback as a registration process can possibly be for providers who are going to be new into registration. So Jill's team, we've worked very, very hard with the trade press. We send regular communications to general practice. David Haslam has done an enormous amount of work for us with the professional GP community. And we have certainly got the metrics that demonstrate that this has been the most efficient registration process that CQC has undertaken to date.
Would it be useful or easy to get some more structured feedback from GPs?
I think we've got it. I'm sure we did some provider online survey work with GPs on the registration process. I haven't got the figures with me, but I know my team have done some work on that, so I can make sure it's circulated to the board. And my recollection was it was positive. It was definitely positive. What I don't know is exactly the level of positivity, but it was a good result.
I think it would be good to have that because there has been so much criticism in the past about when the dentists were done that it was all the criticism had. I think it would be useful to get that feedback, John. Thanks.
David, could I just add my understanding from the stakeholder committee is that the response to the process the way the process has been undertaken has been broadly positive, and it certainly has been much less dogged by problems than previous registration tranches. There is still, though, some residual anxiety about the level of work needed to go through the process. And particularly, you will know from other items on the agenda that there is considerable anxiety about fees being levied. So I think that it's important if we are going to do any work to assess the reaction of GPs, that we don't try and exclude that whole issue about coming into the framework and particularly being asked to pay for it.
Just a couple of other points I'd like to draw your attention to is the first one is reports publication. We set targets for the number of reports issued within both 10 days and 25 days of the site visits. 74% of reports have been issued within 25 days of the site visit and 73% within 10 days. So the 73% is short of our target of 90%. However, we are seeing significant improvements on the prior year and significant improvements on the position at the beginning of the year.
I must say, when I read through the stats, they did stick out. That is not quick, is it? I mean, have you, Amanda? I mean, am I being? Is that an unreasonable view? But I mean, 90% seems to be the right kind of place to be.
We were aware at the beginning of the year that we were going to be making system changes that would increase our efficiency. They were rolled out from August onwards, so we are now seeing improved efficiency. But it's important for the board to note that we have had, certainly in recent weeks, a number of system outages that have impacted on the publication, the availability of publishing final reports. But it's not an unreasonable expectation that we get our reports out in a timely way, and we'll continue to focus and improve efficiency around this indicator.
Initial getting back to the person you've inspected, because for them it's a big deal. A huge deal. Reputationally, it's a huge deal, and I think if you don't get back to them in good time, it does devalue what is actually a really important, sort of seminal moment for the provider.
I think you raised a very important point, Chairman, as well as focusing on the efficiency and productivity of the inspection reports. We've also put time and attention through some of the work around strategic working with providers in making sure that we give a more consistent approach to immediate feedback following an inspection. And again, that's been something that's come back to us both from providers but also in the adult social care sector from residents and their relatives, that when there's been an inspector on site, they like to get feedback as soon as possible from our inspection findings.
Just one last comment, if I can. I mean, I don't know what other board members feel, but there's a lot of information here, and I have sort of got to grips with some of it, I think. But it would be helpful to me, David, if you, for next year anyway, if you picked out what you thought were the most important sort of KPIs in here. Maybe it's 10, maybe it's 20, but it's not 50. And appended them to your chief executive's report. So, I mean, that's not to say that a lot of the stuff in here isn't also useful, but I think it's just that some is more useful than others, I guess, is what I'm saying. Would that be?
I think, as I said at the beginning, Chair, you know, this is one of the issues we've had in the early days of CQC was getting the information. The board continually requested, and as we've got more and more information, this is built up. But an exercise is going on at the moment to condense the KPI report into a more meaningful, perhaps 15, 20 KPIs for the board going forward from the 1st of April.
Well, I think this is useful for you as the executive team. I'm not saying scrap what you've got here. I'm just saying, for us, maybe a bit more discriminating. John, Steve, and then Kay.
Chair, thank you. I don't want to go into detail on this. I do want to say two things. And I support, first of all, it is to support the point you've just made about distilling this to a shorter number of key performance indicators. And the second area is that when we do get those, this is simply a means to an end. This management report is not an end in itself. It is a means to an end. And it, for me, highlights two areas. The first is that it offers the opportunity to highlight areas that are not going according to plan, which are marked by red indicators. And where that happens, I think there is an obligation on the executive to explain in summary terms why that has happened, and perhaps more importantly, what is being done to get things back on track. Or perhaps nothing can be done to get things back on track. It is a done deal, in which case that needs to be explained. And I think, for me, there are a number of places where there are red indicators. Some of them are executive level matters, others are matters which ought to be of concern to the board. But what I find frustrating is a lack of understanding about whether the situation is retrievable, what is being done, what could be done, what should be done to get it back on track. That's the I'm not asking for an answer now, I'm just making that point. That's the first point. The second issue is what does this tell us? And for me, there is some quite worrying data about what the inspections are showing. not the fact that the programme is taking place, but what the product of those inspections are. And in particular, that the level of non-compliance that is being found seems to be either constant, stable, or growing a little bit. Now, that for me is very worrying. As we go round and round and round again on repeat inspections, to find a situation where apparently providers are not improving, they are failing to meet whatever we call our standards, essential, fundamental, required legal standards. They're failing to improve. I think we need some sort of analysis about what is actually going on in the sector. And it's that which I would like to see happening in the future. In other words, what can we learn from this? What can we learn from the inspection product? And what can we do about that? Where ought we then to be targeting and deploying our resources? And I don't know how we can do that. It's not a discussion we have on the management information report. It's what the management information report leads to. And I think I'd like to reinforce the point you made, David, by asking the other David Bean, if he could give some thought to how the distillation of the conclusions can be brought to the board.
Yes, I think a similar point. I think I'm going to make a similar point.
Sorry.
Right, I think I'm going to make a similar point. I think congratulations have to go to Amanda and her team for the effort that's going into the inspections to meet this target. And I do welcome Amanda's reassurance because the same concerns do rest with me about the quality of those inspections, because the pressure is clearly on. And so in that sense, the reassurance is good. But where I'd like to see John distill or refine or improve the performance figures is so that we actually have got more than reassurance. So there is a section in here, section 2, which is about delivering and improving our regulatory and other functions. Fine. But there isn't, as much evidence here as I would like. And I don't think it's easy to find these indicators, but I think they're the ones we need to see, so that, John's points about, organisations that are continuing to fail and are non-compliant, that we actually something about the quality of the services that we're measuring, rather than just the process. Because although the process is important, it does obscure some of the bigger issues, and that's a concern.
Yeah, on the performance framework, I think, particularly given the comments by other board members, I think it's really important that the whole board inputs and agrees the framework. And it does need to be very tightly tied to our strategy and business plan, because, it's a crucial, if you like, mechanism through which we kind of discharge our duties. And we need to be, confident that the information that we're given actually enables us to do that. So it is important for all of us to kind of own it and input into it. So just a few kind of specifics. Firstly, I would agree with Steve. I mean, it's, the effort that's being put in to increasing our numbers of inspections, it's very, very impressive. And I'd like to sort of thank our workforce for working so hard. So two very specific things. I noticed that on new locations, there's 84% that haven't been visited as yet. And so I'm asking for assurance, really, that the same sort of quality and risk analysis has been done on those, with a view to, identifying services that could potentially be at risk. So if it's the same criteria for assessing whether they should have been inspected.
Could you answer that one, Amanda, before you could have a point, I know, but just answer that point before we lose it.
In terms of the new locations, as the board will know, the target, so inspections that count against the 5 outcomes, are those that were registered as of the 1st of April. Where we receive any information either through a registration process, any safeguarding information, we will go out and we will do a responsive inspection regardless of the time from point of registration. I think it is something for next year's performance framework and certainly the strategic work around registration, whether the board might want to consider in future that we have a mandatory timescale for follow-up of all new locations, because what we can't guarantee with the current process is that you are covering off every possible risk of a new location. So I think it's a very important point and one that the board might want to consider how we might mitigate and address further.
And the other point is around SOADs. I think it's improving, which is good because it's been a real challenge for us. I'd like to kind of understand, if you like, the trajectory. I mean, are we going to, at some point, do we know, reach a point where we're sort of hitting our time scales? And also an update on how we're, seeking to improve our SOAD capability.
Very happy to address that point, Kay. Overall, it's absolutely right that the picture has been improving for some time now in terms of our SOAD capability. The real issues, as you'll see in the scorecard, relate to effectively the 3 areas where we need a quicker response. That's because of the lack of numbers of SOADs that we have. We did have, as the report says, 80 expressions of interest to join the SOAD workforce, which was very helpful. We had great hopes for that. Unfortunately, we have another 20 or so to interview, but of those we've interviewed, only 15 have met the standard. I think what that says very clearly is that we have some very capable clinicians, but to be an effective SOAD, it goes back to the point around the ability, the competency and the confidence to also challenge decisions from fellow clinicians and to talk to boards and organisations in an effective way, as well as a really good understanding of the law. And it is quite complex in this area. There's some very specific case law. So we're continuing with that work. Spoke to HR colleagues about this. We will go out and continue to try and recruit the people that are out there. I'm also meeting with the president of the Royal College of Psychiatrists myself in a couple of weeks' time to see if there are any system issues we can unlock. So it is improving. The staff and those SOADs that we currently have been redoubling their efforts effectively, and that's something that I know we looked at, Louise, and within the audit function to say that the activity is rising. The longer term fix will take us a bit of time to get there, but we are on, to answer your question, on an upward trajectory. It will take time to be in the position that we absolutely need to be in, but certainly since June there's been significant improvement.
Yeah. And just quickly to say that I do support keeping the eye on the quality of the SOADs, because we are looking at treating people without their consent. So, I'd support keeping a very strong eye on the sort of quality of the SOADs and competencies. Yeah.
Could I just say, for that reason, we very, very helpfully had the agreement about recruiting a principal SOAD who will look at the quality of the opinions that are made. Clearly, in terms of clinical opinions, one needs a more senior clinician to take that role on. So I think that's absolutely right. I would agree with Kay. We need to look at quality as well as meeting a very necessary target in this area.
Thanks, Philip. Just, Amanda, on the 2 questions that came from John and Steve, getting a handle on this added value really is quite difficult, and I'm not sure how you can do it, but could you give it some serious thought over the next sort of 6 weeks? And David, I don't know if you'd like to pick that up as well. This is not an easy area, but it is important, I think. It's looking at where hospitals, just picking on hospitals for a minute, going from minor concerns back to green, or from major to minor to green, or whether not going anywhere. It's getting a feel for that sort of area, I think.
So if we can just connect the conversation we had right at the beginning of the meeting about bringing forward a list of hospitals where there are continuing concerns, I think these are one and the same thing, and therefore the depth of the analysis are one and the same thing. So it's not just why people are where they are, but what does this tell us? Let's go back to conversation around Francis and our strategy. What is the culture of the organisation? How are challenges to quality standards taken forward? And I think we need to combine that with the harder data around standard mortality, etc., etc. And that's the report that I anticipate bringing to the board, and I've had some discussion with Amanda first thing this morning about how we'll do that. So I think in brief, Chair, we'll combine this latter request on the back of the performance report with the earlier conversation, and what I've got in mind is a compendium report which again shows what unilateral, and it might be on minor and moderate complaints, multilateral action, which might be where there's major complaints and we're actively engaged in action with Monitor and or the Trust Development Authority, and indeed we might be involved in discussions with the Department of Health. And I think what I've got in mind is a report which makes it absolutely clear by institution what our engagement is and why. What we are doing, what others are doing, and there'll be a narrative field in there which will say what intelligence we hold on those, which actually informs some of those judgments about the degree of risk. So that's what we'll work out how to present as simply and clearly as possible, and that's what we'll bring. And that should cover off. I'm not sure what page it's on, but the charts which are on 12 and 13. Yeah.
Are you happy with that? I mean, it seems to me this is the heart of what we're doing, really.
Feed into the evaluation work, because if we do develop this sort of idea of, is it auto-evaluation, where we do it as we go along, because I know it just seems as though there could be a sort of connection there.
Thank you. John, have you almost finished your report?
I have. There's just one other thing I want to bring to the board's attention. There is a detailed finance report attached to the report and the KPI report. At the end of Q3, you'll see that we're running some 5 million below our expenditure budget. The board will recall that we set aside 4.5 million to cover the additional costs in the second half year of bank inspectors, overtime, etc., to achieve the inspection target. Our full year forecast shows that we will probably be there or thereabouts on the budget at the end of the year, given the additional costs incurred on inspection and other costs to be incurred in the final 2 to 3 months of the year. So we won't be significantly short of budget come the end of the year. And we will use most of our allocated 154 million for the year.
I just wanted to remind the board that we do have the market report that comes out twice a year, and the market report attempts to explain why we think some of the areas of non-compliance are occurring across the sector. So that it doesn't answer all the questions, but it does sort of take it back a few layers. We work with providers and we do a lot of deep analysis with the intelligence team to try and understand the why. So that is a twice annual report which I think complements this reporting.
Does that name hospitals, or is that a general view that's across the piece?
It's much more of a general view across the piece, but what it does do, though, it does get into what challenges they're facing and why some of the areas are non-compliant. So I think it's important background to understand that. That's what it does.
I sort of suppose, maybe I'm being a bit unfair, that sort of falls in the really nice to have category, and it's interesting and it's informative, and I think it can be used by people in social care or hospital care. But in terms of stopping another mid-staffs, it's not it.
No, it doesn't do that.
Yeah. John, thank you very much for that report. The next item was the strategic business plan. I think, and I talked to Jill about this, David about this yesterday. It seemed pretty pointless coming forward today with a business plan when we've got so much going on, and our business plan and the strategy is changing shape, in the light of the Francis report, which David talked about earlier. So I think if it's all right with the board, I would like to park that business plan until the next meeting, by which time I think we'll be much clearer about where we're going and how we're going to resource it. But I think a key part of that plan, when we do it, will be informed by the work that Kieran Walsh has done, looking at looking at it from a more sort of academic perspective, but actually, when I was originally told, not knowing who Kieran Walsh was, that an academic was doing this, my heart sank. So I thought, I won't understand a word of what you're writing about, and it will be so theoretical as to be not very helpful. But actually, he's produced a report which is extremely clear and I think really very helpful. So, Kieran, you've got a few slides to show, I think, haven't you? And
that is the academic disease, not to be able to speak without slides.
So over to you, Kieran, please. Thank you.
Thank you very much, David, and thank you for the invitation to come to the board today. I have a few slides, and what I've prepared is about 10 minutes of introductory presentation to the discussion about this piece of work. In undertaking this, when I had my early dialogue with Philip in particular, I think we were being asked to try to help the Commission to understand how evidence more broadly might be used to help inform its decision making, how we might help to use research and evidence from the work that CQC itself does to think reflectively about the impact and effectiveness of regulation and the way in which it improves the performance of regulated providers. And we approached this in the piece of work, I think, in two ways. One of them was to undertake a review of the current regulatory model and to try to understand how that model was constructed and how it worked. And the second way was to look at a number of areas, and we talked with Philip and colleagues about identifying those areas, differentiation, standard setting, risk assessment, and the inspection workforce. And in each of those areas to try to draw together the evidence that we thought would be useful. And the evidence there came from three sources, I think. It came from what we know in the literature about regulation. We looked at some comparator regulators to try and understand their practice in these areas. And we did some work to look at what data CQC had and what it already knew about these areas. So what I prepared is a short presentation where I say something briefly about the regulatory model, but mainly focus on those four areas and what I think we may be able to learn from the work we've undertaken. The report, as you said, spends some time in Chapter 2 talking about the regulatory model and how it works. And we have talked about this before in a meeting with the board, so I'm not going to reprise that, but to try and focus on what I think are some of the lessons from that piece of work. It did raise fundamental questions, perhaps, about the mission and purpose of the Care Quality Commission, and particularly the tension which emerges in the Francis report yesterday, but which has been an issue for the Commission throughout its life, the tension between assuring the quality of care at the bottom end of the performance spectrum, dealing with the providers who may be failing to provide essential standards of care, and also seeking to improve care across the range of regulated providers and across the health and social care system. I think it also raised, for me, questions about the way in which the Commission thinks of itself and its remit. And we raised two questions, I think, in the report, one of which is to do with to what extent the Commission looks at its legislative powers and seeks to use them to achieve a set of objectives, or to what degree it sees its legislative powers and the rules and regulations as the definition of what it is there to do. The second question, which actually again is also very much touched on in the Francis report, is about the relationship between the Commission and the rest of the community, the regulated providers, the other regulators and the other actors in the landscape. I think in the work on the model, we concluded that, and I think it received some assent, that the model up to now has been very much focused on safety net regulation and on dealing with, or trying to deal with, providers at the bottom end of the performance threshold, performance spectrum, and that one consequence of that is that it is much less well placed to deal with driving improvement across the health and social care system. Even in its own terms, we thought there were some important issues about how the model worked at present, and we flagged those up as being particularly the generic model and how that worked in practice across a quite heterogeneous set of health and social care organisations, the processes for risk assessment, and the mechanisms for information provision, for providing information to the public and to stakeholders. And that's talked about in the report. But coming back to a point that you raised, David, right at the outset in talking about the Francis report, I think I'd suggest that a consequence of focusing on safety net regulation is that you inevitably constrain the impact that you will have on the provider community as a whole. So very practically, in the 30,000 or so inspections that you undertake every year, if 75% of providers are found to be compliant with all your essential standards, as more or less speaking they are, then about 3/4 of your inspections are on providers who are compliant. 3/4 of your inspections tell you very little about those providers and probably have relatively little impact. So the argument I would make is not that there is an either or here, that you focus either on the safety net or on improvement across the system. But if you focus only on the safety net, then I think it makes it very difficult to drive improvement across the system. And the consequence of that is that when you do the sort of value for money calculation, you've put a lot of regulatory effort into inspections of organisations who are essentially compliant and were probably compliant last time you inspected them and will probably be compliant next time you inspect them. Of course, the strategic review and Francis articulates them. I'm happy to pause. I'm very happy to stop. Yeah.
Well, I think that's core to what we're talking about, because at the moment our new strategy and new purpose is to drive improvement. And what you're saying is that we can't do that with the safety net inspections that we're operating at the moment.
Yeah, I'm saying if you design your whole process around just the providers at the bottom end, much of your effort, regulatory effort, is essentially going to be wasted is perhaps too strong a term, but not particularly productive, because you'll inspect people who will clear all the barriers with ease. So that's why I'm suggesting if you want to drive improvement, you need a model that doesn't simply focus on the safety net. If you were really going to just focus on the safety net, then, to be honest, you wouldn't inspect the 75%. You'd find ways of trying to not invest regulatory effort on them, because you would find ways of trying to know that they were compliant in other ways. That, I think, is difficult.
So, just to conclude that point, the safety net procedure then is not going to work. Is there any way that we can adapt it, change it, amend it, alter it, improve it, so that it does work? I mean, is there something about raising the standards year on year?
I'm going to come to some of this, but I think if you are going to be a safety net regulator, then you probably don't adopt a model in which you use universal inspection.
Can I just interject there, Karen? Because, I mean, we are fundamentally a safety net inspector. We are to catch those organisations that do not achieve the fundamental standards. I mean, that is absolutely our goal, which then takes us into the risk-based method of investigation, I think. Is that correct?
I think that is a fundamental goal for the organisation, is to deal with performance at the bottom end. The question I think I'm raising is whether you construct your mission as being solely about that, or whether you regard yourself as having two tasks, one of which is to make sure that you deal with performance at the bottom end, and the second of which is to drive performance across the system. A real challenge, of course, is that if you or other stakeholders think you're not doing the first task well, they may have less confidence about you taking on the second task.
Okay.
Shall I carry on? And the strategic review clearly articulates some potential changes, particularly around that issue of driving improvement, and so does the Francis report. The four regulators we looked at to compare practice with were two healthcare regulators, one in the United States and one in the Netherlands, and two regulators in England, but with different sectoral concerns. So Ofsted, with its responsibilities across children's services, and the Homes and Communities Agency, which regulates social housing. And if I'm honest, they were a convenient sample of regulators. We chose two healthcare regulators where we had existing contacts and where we knew we could get the information we needed, and two UK regulators where, again, we had some existing relationships. So I was going to go on to the four areas and to try to say something in each area about what we found. The first area we looked at was differentiation in regulatory design. This is the question of whether you use the same regulatory standards and processes across the piece, or whether you adapt or adopt your different systems in different parts of the regulatory domain. What we found looking at other regulators is that all the multi-sector regulators do differentiate, and what they would have sometimes were common methods or processes, but tailored standards, tailored forms of guidance and information for providers, inspection staffs to work in particular content areas, particular sectors, and that they would vary things like intensity of oversight, frequency of inspection, those sorts of things across their different parts of the regulatory domain. So differentiation is pretty much the norm in multi-sector regulators, and there is in the literature some sort of rationale for that it's partly about the size and scale of sectors and their complexity, adapting to level of risk, adapting to the size of the providers. In other words, the tools you use when you're regulating big organisations are quite different from the ones you use when you regulate very much smaller organisations, and also adapting to the range of performance that you find. Now, in a sense, I may be sort of saying things that seem obvious after Francis, but it seems that you could now differentiate more in your regulatory regime in particular sectors, and the place to start would seem most obviously in the largest sectors and those with greatest heterogeneity. So I guess in the NHS and in adult social care are potential places to begin. The second area we looked at was standard setting, and David, you alluded to Francis's use of the term fundamental to describe the standards that should be set. The term essential has been used by CQC to talk about its standards. I think what we found was there was real variation in the approach to setting standards by other regulators, from the Joint Commission in the States, which has essentially a large and long manual of standards, 18 standard areas with multiple criterion within them, to an organisation like Ofsted, which has essentially 4 domains: achievement, teaching and learning, behaviour and safety, and leadership, which are not too dissimilar actually to your 4 domains in Darcy. What we certainly found with the 2 healthcare regulators was that they tended to have standards that were more maximal or more discriminating in their nature, and to involve the sector in framing those standards. Indeed, the Dutch healthcare regulator, the standards are set by sector organisations, professional associations, and the regulator uses those standards. So it seemed to us there was real potential to pilot the development and use of tailored guidance and tailored standards, which is something that from my understanding, you've already begun to do through things like themed inspections. And there's clearly the opportunity, and it's flagged in Francis, to pilot the use of standards from other sources, such as NICE's quality standards. The third area, risk-based regulation. When we looked across the other 4 regulators, I think what we found was that they assess risk at a sector level. So, for example, the Homes and Communities Agency has a different regulatory approach for large social landlords and small social landlords. So those with under, I think it's 1,000 homes, they have a very light touch regulatory regime with. But what we found was less of an engagement with assessing risk at the individual organisational level. So the 2 healthcare regulators we looked at essentially have fixed regulatory cycles. So the Joint Commission visits acute hospitals once every 3 years. The IGZ undertakes an inspection annually of each acute hospital, with some adjustment of that in response to organisational performance. So, for example, non-compliance is used to bring forward the process of inspection or to trigger follow-up and repeat inspection, but not much use of the data, despite the fact that those 2 healthcare regulators collect an enormous amount of data about the performance of the organisations. What they said was that they didn't have sufficient faith in the predictive value of that information to, for example, say, on the basis of that data, we no longer need to inspect that organisation. Of the 4 regulators we looked at, Ofsted is probably the prime example of one which does, at the moment, say, if a school is outstanding, it has no defined period at which it will be re-inspected. It monitors those schools annually on their achievement and then decides whether to return to them. It seems that the data that perhaps you could be most sure about in using to risk adjustment is the data from your own inspection processes. And that's what other regulators certainly do. So you could consider using risk assessment, but basing it primarily on the data you have from your own inspection feedback, rather than doing as CQC tries to do now with quality and risk profiles, which is to gather data and then produce these risk predictors.
Kieran, I think the big difference between an acute hospital and a school, for example, is an acute hospital is vast, and our inspection is very narrow. I mean, it's looking at a couple of outcomes in a couple of wards in a hospital that might employ 10,000 people and have 35 wards or 40 wards. So in a sense, relying just on our inspection is not enough, I wouldn't have thought.
And I'd respond to that by saying and there's some discussion of this in the report, that I guess raises questions about the nature of the inspection methodology, because the inspection methodology you use with a small organisation can rely predominantly on direct observation of processes and care, whereas with larger organisations, if you do that, you're assuming that performance in one bit of the organisation is a proxy for quality of care everywhere else. And in large multi-service organisations, that's probably not a particularly robust assumption.
I mean, what you're saying is we've got to have a different approach to inspection, rather than rely on something else. Like the QRP type, we could choose to rely upon or rely more on a more sophisticated or a more connected QRP process, or we could do a much broader inspection.
I think I'd have real doubts about whether you can. I think you've invested lots of effort in developing QRPs, and in the health sector have a lot of data to draw on. I still think it's probably true that they're not very good at predicting risk. They may be really useful as a way of steering the focus of inspection, in the way that Ofsted will use examination performance data to decide that when it visits a school it will focus on particular curriculum areas because the data tells it that's where the issues are. I'm less sure that the QRP data is useful to you, for example, in adjusting the periodicity of inspection. What I'm suggesting certainly is that inspection data is and we come to this in talking about the nature of the inspection workforce, but inspection data from a robust and informed and professionally shaped interaction with the organisation is probably more useful than the data that you might gather from the QRP.
Yeah. I think I was kind of struck by you saying that we go and we look at one or two wards and then use that as a proxy measure for other wards or other units. And we have been criticised, if you like, through saying some areas meeting standards is good, and yet the next day in the same hospital you get some sort of horror stories. And I think that there's, one way of looking at it is that, we potentially give false assurance, and we need to be kind of clear about that, because that in itself seems to me is quite risky. I'm just thinking of mid-staffs. I was listening to Peter Carter this morning, and he's famously said how wonderful the nursing and the wards were at mid-staffs, and they may have been on those two wards, but of course on the other wards there was some really appalling care, and so there is actually an inherent risk of giving sort of false assurance by basing our judgments on just one or two wards or units. And I think that is a real issue for us and for our model going forward.
I think that's right. I think what you're saying, aren't you, Kieran, is that that's a comment on our inspection methodology, that actually, because Kay is right in what she says, she has to be right, and that you're saying that we've got to have a different approach to inspection.
Yeah, the larger the organisation, the more, I guess, you need to ask questions about the systems and processes in the organisation to assure the quality of care. And that doesn't mean you don't also use direct observation, but you use the two alongside each other. And that may be true of large organisations. It may also be true of chains of organisations. So, for example, chains of nursing homes, where there's potential to use a combination of sort of corporate questions and inquiry alongside direct observation of care.
I just would like to press you on one, going back. I agree completely with what you say on that, but just on the QRP approach, I'm surprised that you're, in a way, that you say how little reliance you can place on that. I mean, if the QRP is looking at patient experience, staff surveys, HSMR, clinical outcomes, and and factoring in the noise in the community, the voice of the community and stuff, I would have thought that did give you a pretty good methodology of determining the risk that something was going wrong in that organisation.
Well, we can do some work to try and understand whether that is the case. And we did in the report look at the data in adult social care on QRPs and compliance at subsequent visits. And there's a predictive relationship, but a relatively weak one. And if you're going to make judgments at a sort of population level across organisations, then a weak predictive relationship may be helpful. But if you're going to take decisions about individual organisations, shall we inspect this organisation in the next 6 months, you probably want stronger predictive data. I guess my response to your point is that all those sources of data are really important. So the staff survey, the patients that survey, the HSMRs and so on. But there needs to be a kind of intelligent judgment process that brings that data together, which perhaps is not so much about risk indicators and dials, but about the interpretation of that data and also the understanding of how the organisation itself responds to and uses that data. So, on risk-based regulation, I guess I'm sounding quite a cautionary note and saying that adjusting things like the frequency of inspection based on organisational performance can certainly be done on the basis of your own inspection findings, where you have, strength of information that tells you, for example, that you need to follow up an organisation more frequently because of its non-compliance. But it's more challenging, I think, to do it on other sources of data. And the fourth area we spent some time working on in the research project was on the workforce, the people who undertake inspection, and the common lesson from the literature is essentially that inspectors need competence in the content domain in which they're working, that they need competence in regulatory process, and that they need very strong interpersonal skills to deal with the business, the process of inspection. What came across from the comparator regulators we talked to was how much value they place on the professional judgment of their inspectors. And on the people skills of their inspectors. And all the other regulators we looked at, the 4 comparator regulators, use relatively senior people who are experienced in the content domain in which they work and who are frequently qualified in that content domain. For example, who are doctors and nurses inspecting healthcare organisations, social workers inspecting social care organisations or whatever. They also invested, and there's some data in the report about this, quite a bit in their training and ongoing professional development. So I know that there are some plans to do an audit of CQC's existing inspection workforce to look at the questions of content and regulatory expertise, which I think would be a very productive thing to do, to get a better understanding of the range of existing experience, existing qualification, the extent to which inspectors do carry mixed portfolios or in fact already de facto to some degree specialise. And I think there's also potential to do some piloting of specialisation in some sectors. And of course, again, Francis has rather shut my fox there by saying that there ought to be a different approach in the NHS particularly. Now, an area that we didn't touch on in much detail in the report, but where I think so I make a tentative suggestion here, is that it's also worth looking at the training and development programme for inspectors and thinking about the process by which they are both trained when they are first recruited and the way in which their CPD is attended to. I
think there's some really big points in there, David, about our inspectors, training, ongoing development, qualified, keeping up your qualifications. Do you want to just comment on that?
I completely agree. I think, I don't know who shot whose fox as we're late, but if we go back to the strategy, one of the big things from the strategy was specialisation and genericism. It was about the background of inspectors. The word competence is often used by people. Confidence is used. So there's an alliteration around the C's that ends up being played through these conversations. Francis, yesterday was unambiguous on this point, and Kieran, in the drafts that you've been preparing, your presentation last autumn now, of the early signs from your work, this has run through as a theme. I think I had 5 emails yesterday from inspectors saying, about time, thank you. So there is a sense, there's a moment here. Alison and myself have spoken about the survey that we're doing, so that we really tap into the richness. One of my questions is not just how many nurses and social workers have we got, but are they still registered and are they maintaining their registration, and do they see that as a priority? Do we as an organisation want to encourage our professionals to continue with their professional development, to have people let their registrations lapse? So that's some of the richness that I think we need to get at. And then I think once we've set our strategy moving forward, I think this issue about what our offer is to staff, how we support staff to do the job we're asking them to do, is a particularly critical issue. And I suspect we're going to move into a place where some staff will be leading teams which will have experts in them, doctors and nurses and other clinical professionals, so that when we go into the organisations, we cover the range of issues we want to pick up. This is why I think this issue about predictability versus these are questions which allow you to ask questions on which we then make judgments is a really important issue to tease out, because the skill mix we need then on some of our inspection teams is going to be determined by that data and the questions or judgments I think you're referring to, Kieran. Yeah. So I've got a view that we will need a range of experts. So in one hospital we might need to look at paediatric cardiac surgery. But with the best will in the world, we're not going to have a banks of inspectors on our payroll which have all the expertise. And then the next hospital, it'll be pathology and breast screening services. And the next hospital, it'll be stroke care. I use all 3 of those because this past 6 months, we've had to source inspection teams which have all those experts on in order that we can go into the hospital. So I think there's this issue about what is our core staff, what is the people that we need to be part of the inspection teams. And I think, David, the point that you've been making around culture and governance, I do see some leading chief executives being part of these inspection teams at times to make sure that there is an expertise around what governance from the board straight through an organisation needs to look like in these organisations. I think this picks up on your point that part of the assessment of risk is how open organisations are to feedback and challenge and how they take it forward. So I think it's a powerful, powerful report that some will find uncomfortable, but they're all important questions that we need to ask and answer as we move over this next few months.
One thing I would add that David reminded me of was in undertaking this piece of work, we went and spoke to quite a lot of people from CQC and here in Finsbury Towers, but also in one of the regional offices. And I would say universally, people were very supportive, very open, had lots of interesting ideas. And I was impressed by the inspectors I met, and frequently they'd worked in this organisation in one of the predecessors. They had loads of experience of inspection. So I don't think that this is necessarily an agenda that people who undertake the process of inspection are going to find difficult. It's one that I think they'd embrace, the people I met.
I mean, Amanda, can you just comment on that? What's your view? Sorry, Amanda, what's your view of whether or not the generality of our inspectors, whether they are up, they've got the right training for this expertise?
I think we've made significant strides in the last 12 to 18 months in developing a training and development framework that's around having a core competency set and then a modular development programme that picks up on specialisms. The challenge that we've had that's covered in the Robert Francis report yesterday is evolving an organisation, bringing together legacy ways of working, legacy knowledge, legacy skills and competence, and having to register and introduce into a new framework 40,000 services. So I think we have got a significant amount of expertise in what works as a regulator, as an inspector. And I think we now have a fantastic opportunity to build and segment amongst those 40,000 services so that we can add real value by looking at services, by looking at governance, by looking at how well the care is delivered by this organisation with a mix of people who are doing that in their day job. And the staff that we've got here who can coordinate and build those skills and form judgments.
Wrapping up, I think.
Yeah, I mean, my final slide just said, you know, clearly the change agenda is really substantial over the coming months and a couple of years. And my plea to you would be to pilot the changes you're going to undertake, to test out whether they work. I think because of the scale of CQC, you can pilot things really quite quickly. You know, you're doing a couple of thousand inspections a month. You've got a great opportunity to pilot, test out, and then roll out changes relatively quickly. So piloting doesn't have to be a barrier to change at all. And I would hope that also the routine data you collect from things like post-inspection provider surveys, from other sources, will give you better data in the future to be able to demonstrate the impact of the processes once they're mainstreamed and once they're ongoing. So thank you, David.
Karen, thank you very much for that. We asked questions as we're going through the report, or any other sort of... Kay, yes.
Firstly, I think it's a great report. And I think just looking at the first conclusion, which says that the regulatory model is probably not sustainable and requires change and development. Sort of perhaps not surprisingly, I think that I'm in wholehearted agreement with that. And I'd even go as far as to say that one of the main reasons I went to the Mid-Staff's public inquiry was on this very issue. So from my perspective, the fact we've got some of this in black and white is really helpful and useful going forward. A couple of other things. I met with one of our new inspectors yesterday for coffee, and she was very positive and enthusiastic. And her background was in mental health and DOLS. She knows a huge amount about that. Deprivation of liberty safeguards. We've got a specific duty around that. And she was obviously a little bit worried about going to sort of large hospitals and dentists and beauty clinics because that wasn't her background. She also said, oh, we only had a couple of hours training on DOLS. So it seemed to me that just that simple conversation just underlined how much we do need to move to more of a sort of specialist type model, because we're putting people in situations where they don't really know enough. But also we're not making the most use of the skills that some of our inspectors have, actually. You know, this individual, for example, could have run a training course on deprivation of liberty safeguards. So that's very helpful. The other aspect, and it's not included in this, which is sort of very close to my heart, is around involving service users, patients, public, if you like, in our inspections, the experts by experience, the acting together. I mean, I certainly would want that to continue, and I see that as not a sort of should we do it, but how should we do it? And I know there's some evaluation work going on around that. But I think, you know, as we go forward, it will be good to think about how we can sort of optimise that involvement and how that fits with sort of local arrangements and Health Watch, because we do potentially get a lot of sort of information about the current and direct experience of people using services. So just putting it down a marker there. Okay, thank you.
I think we're absolutely committed to using users by experience, you know, in our inspection teams. And the point you make about that's a good illustration of the importance of a specialist inspector. Right, yes, John, quickly.
David, could I just ask a very quick question? It's on the comparative study of the other regulators and ourselves, which I always find very illuminating. And I just wanted to ask about the productivity of the Joint Commission for the Accreditation of Healthcare Organisations, which seems to regulate about the same number of organisations as the CQC, which struck me as slightly odd, given that the United States has got 4 times the population of England. But that's not the purpose of my question. They do the same number with less than half the number of staff that we have. And I just want to know whether, are they amazingly productive, and if so, how? Or is there a misrepresentation in the sense that they have lots of other people that they bring in? This is the permanent staff, and they, like Ofsted, have contractors and so on. I don't necessarily have to have the answer now, but I'm intrigued, and at some point, an answer to the question would be helpful.
Yeah, I mean, I might perhaps talk in more detail about it afterwards. Comparisons are a bit invidious because the different regulators make different uses of full-time and part-time staff, and actually getting a figure out of, for example, Ofsted for how many staff it has is difficult because many of their inspections are actually undertaken by contracted organisations. So they don't employ most of the inspectors; they only employ the HMIs. In the Joint Commission's case. I couldn't get very clear exact figures out of them, but they try to have the majority of their inspectors as part-time inspectors who have existing roles in organisations. Often there'll be a medical director or a director of nursing somewhere, and they commit about 25% of their time to undertaking inspections. And they have field directors who are employed by the Joint Commission who actually oversee the inspections, coordinate the inspections, and that's not an unusual model.
Is it a voluntary accreditation?
Yeah, I mean, the Joint Commission, I could major on the Joint Commission for a while. It's a very strange setup because the Joint Commission is a private, not-for-profit organisation, but Joint Commission accreditation is mandated in the federal legislation for Medicare. So if you want to treat Medicare patients, you either have to go through Medicare's own relatively bureaucratic accreditation or have Joint Commission accreditation. So it's a rather odd American compromise, which means that they've got kind of a slightly privatised form of accreditation, but it has got real leverage because in order to get Medicare reimbursement, you have to have accreditation.
Thank you very much indeed, Kieran. It's a really good report, and we'll be following it up with some more discussions with you, I'm sure. Yeah. I think we're going to take a 10-minute break now for coffee. Anyone wants a break? But literally just 10 minutes. We'll start again in 10 minutes. Okay? Thank you. Right. The next item on the agenda is a very quick review of the Deloitte's report. David.
Thank you, Chair. So this was a piece of work which the Audit and Risk Committee commissioned. Deloitte were commissioned to do this and invited Steve Bundred, the former Chief Executive of the Audit Commission, the former Local Authority Chief Executive, to contribute to this, given his background in this work. So what you've got in your papers today, Chair, is the final report from Deloitte in relation to the brief that the Audit and Risk Committee asked them to discharge. Broadly, they were asked to consider the use of Section 48 of the Health and Social Care Act, which is the investigatory power that is available to CQC. And what this report does is it considers the use of that power. It's been used 4 times. It looks at the process for how it's been used, how the decisions were arrived at. It says those processes were good. But it calls some questions around what the objective of using this power was and what the impact of the power was. So they make 19 recommendations, I think it is, Chair, in relation to how this power can be used and improved and be taken forward. And they're set out in detail at the report. ARAC have considered this at their last meeting. Deirdre has now resigned and moved on to her position at the General Medical Council as Chair. So it falls to me, Chair, to propose the report to the board. ARAC have already accepted the recommendations. So what I'd want to do is invite the board to agree the recommendations. What we would then do, and this I think is a theme for the morning, is take the emergent work on the business plan, the work from Francis, the work that you've just discussed with Kieran Walsh, and this work, and that is what will be wrapped up into next year's programme as a way of taking this forward. So that's broadly what it is.
Okay, we agree with them. Good, thank you very much. Now we have the exciting item number 6, Philip, the Mogadon item, as I will put it.
Chair, before we embark on this, a lot of this relates to the Francis report recommendation about the way the information is handled inside trust, hospital trust. And I just wonder, is this not, in the light of that, is this not premature?
Are we on Deloitte still? Are you on Deloitte still? Or?
No, sorry.
Okay, sorry.
I'm on item 6, which is what you call it.
Yeah.
And it's the NIGB.
This report has been in train for a while. We saw those recommendations yesterday. So we can certainly, when we go through.
I beg your pardon. Very good point, John. Obviously, the recommendations we've only just seen from Francis. This report, as you know, has been in train for a while because of some very practical issues we have to sort out. I would suggest that what we do is part of David's suggestion around how we look at the Francis recommendations to see if this impacts. But I think David wants to make a comment.
So I think that's absolutely right. My take on this, and I spent most of the time that I spent reading the Francis report yesterday looking at the recommendations, and I think, John, your observation about what the implications are for those about information and data and how it's maintained and kept, particularly because Francis makes recommendations around the exchange of information and therefore the integrity of that information, then I think what he did yesterday is really elevate the importance of the work on the National Information Governance Board. I think what we're trying to do here, we have this responsibility from the 1st of April. So this is a time scale, how much time we've got to think and what we need to do. So I think what this report is doing is wanting us to make some advances on putting in place a committee so we can, and the leading time for this is significant. So I think there's a bit about, let's put some of the, if I may, Chair, just suggest that the debate is about the architecture that we need to start putting in place, whilst alongside this, the work that we've talked about digesting and absorbing Francis's, both the detail and the spirit of his recommendations, and then placing them in this. But I'd want us to beginning to make progress on setting up the committee. The precise appointment and composition of that committee, I think we might want to flex in the light of digesting Francis. So I think it is that permission, if you wish, from the board that you're happy with the policy direction that we've set out, whilst there's some further detailed work to do. I think is the way I'd suggest we try and take it forward. But you're absolutely right, John. Francis does raise questions about this, and it needs to be part of our reflection.
I absolutely agree with that approach. I think it's entirely the way we should go. I think one thing that is quite helpful here is we wanted to articulate what the monitoring principles were, because those have been unclear in the NIGB's previous incarnation, and that was one of the tasks that we're asked to look at. So that's the only thing I would add. We need to move forward with this because of the clearly from the 1st of April we have some statutory responsibilities, but as David said, we can flex those as necessary. So in a way we're asking for, I guess, for the agreement in principle to proceed. We may well have to, we will clearly have to look at some of this and review it in light of things that have been said today and yesterday.
Go ahead.
Can I just check what's been approved?
Paper, but we're going to assess it in the light of the Francis proposals, and come back to the board when we've looked at all the Francis proposals that was part of that, which will be in March, David, won't it?
Yeah.
Okay. Right. Item 7, use of social media. Jill.
Yes, this paper, we did submit a paper with regards to the use of social media as a policy for board members. However, we did not include at the time members of staff, so we are now resubmitting this paper to make sure that we cover both board members and members of staff. The paper makes it clear it's been signed off by both the trade unions and the staff forum. Oh, yes. My apologies for the first version of this paper. We had a problem, I think, with the spell check, or rather didn't have a problem with the spell check for those of you that read it. But it is now correct. But the content of the policy has not changed, just so you're clear. The only thing that changed on this paper that I've just put round now is the cover sheet. So the policy has remained as it was. It's been adapted for staff, and overall, it reflects common sense. And certainly, I think it's fair to say the system works well at the moment with regard to staff and board members being able to tweet, and to also for CQC to engage both at a corporate level and for CQC staff to engage in their own capacity as well. So what this does, though, is just make sure that in the event of something going untoward, we do have a policy in place.
Any questions? Okay.
Okay. I mean, it's very useful to have the policy. I mean, as you know, I've used Twitter quite a lot now, and I found it very useful for engaging with a whole range of people. You know, for example, I've got people following me who are currently detained in hospital. I've got MPs following me. I've got a carer following me. So you can get a whole range of different opinions and feedback. It's a good policy, but I just wondered if it was a little bit too defensive in a way. You know, to me, it doesn't quite. There's not a more sort of positive view of it, because there is a lot of potential there. I mean, obviously, we need to be very careful that we don't, you know, bring the organisation into disrepute or breach confidentiality. But I just wonder whether we've quite got the balance right on the sort of opportunities and the sort of advice on how to use it, to use the, you know, to use social media to its best advantage for the organisation.
I think that's a perfectly valid point, Kay, actually. I think this is more about what you can't do rather than what you can do. I think that's fair. I think the emphasis is more about on the negative side rather than the positive side. So I don't see there's any reason why we couldn't actually, as an organisation, this doesn't have to be a policy, but as an organisation, talk about, we could do this through internal communications, how to use social media effectively and what successes we've seen. I think that's a good suggestion, and I'm very happy to take that forward. I think as long as this, I think it's preventative, this is, but I absolutely take your point. It isn't proactive.
Thank you, Chair.
Sorry, Louise, my thing wasn't on. Louise, your item, number 8.
Thank you, Chair. A short, self-explanatory paper explaining the history of the strategic risk register that we have within the papers. This particular register and the strategic risks contained within it were developed by board, ARAC members, independent members, and various individuals who have an interest in this area within the organisation. 3 workshops were specifically held to identify strategic risks within CQC and were committed to this register, and the mitigating actions relating to those risks were also included within the register. What I would say about this particular register before board members may wish to address it is that, along with probably everything else today, there are a number of areas where we may need to reflect on the strategic risks, and also this is similar for our corporate risk register, which isn't before you today, with regard to the content of the Francis report, also the work that will lead from the recommendations and our plans that come to the board in relation to that, along with the other areas that we've also discussed, for example, Professor Walsh's report, the Deloitte's report. So the strategic risk register that's before you today will obviously need to flex to reflect any of the opinions with regard to the changes to the strategic risks presented to the organisation. For today, however, the strategic risk register before the board, I'm asking you in the paper to consider whether there are any additional risks that need to be captured at this point, whether the tolerance or risk appetite has changed in relation to any of the risks that we have here, 7 of them, and to consider the current net risk levels, and also consider if you require any changes to the mitigations that are presented in the risk register itself.
Thanks, Louise. Any questions for Louise?
Could I just say, this was discussed at the last meeting of the audit of ARAC, and there will be a substantial revision of this in the light of the new strategic plan. So my advice would be to agree this for the purpose of getting us through the next few months, and then we can spend time on the new risk register when we've agreed our strategic plan.
That makes sense, doesn't it? I mean, the key risk has got to be another mid-staffs, hasn't it? I mean, or a winterbourne view.
Perhaps it...
Yeah.
I mean, I think that's right. And obviously, I think this point's already been made, but we are, it seems, going to go through a period of really substantial change. But it is about keeping our eye on the ball as well. So, you know, the business as usual, and making sure that you know, we pick up poor care quickly. So it's
Thanks. Are you happy with John's suggestion? This is going to go to the ARAC and come back after we've done the strategic review.
Yes, thank you, Chair. And also to mention that I think it's the next meeting of ARAC is actually a risk-focused meeting, isn't it? So, indeed, we'll have the ARAC members will have a wider opportunity to consider those.
Thanks very much. Item 9 is also you, Louise. Revised governance documentation.
Yes, thank you, Chair. What the board have before them today is the revised board standing orders and the board code of conduct. Again, the paper, I think, speaks for itself. We were due to review the standing orders in any event, and the standing orders have been amended to reflect certain changes that were necessary, and they are set out on page 2 of the report under the executive summary, near the bottom of the page there, changes to the standing orders. So it's necessary issues, so changes to the membership regulations to provide for an appointment of a senior non-executive member, and they're set out there on pages 2 and 3. The standing orders also make reference to a proposal relating to the scheme of delegation. Now, the scheme of delegation is going through review at the moment and will be formally put to the board in March. And the proposal is that the scheme of delegation be divided into 2 parts. Part 1 relating to matters reserved and delegated by the board, and Part 2 to matters reserved to and delegated by the Chief Executive. And then under that proposal, the board will determine what changes will be made to the scheme of delegation in Part 1, and then the Chief Executive to any changes in Part 2. But that will be coming to the board in March, and greater consideration can be given to that then. Also on page 3, some identification there to the changes to the Code of Conduct, which was formerly called the Code of Practice, attached to the board standing orders, and that's just in line with the revised Cabinet Office Code of Conduct for board members, which was reissued in 2011. So there are, as I say, the paper is pretty much as it says on the tin, as it were. The only other change that I would highlight relates to a discussion that occurred in the last board meeting, or the board meeting before, in relation to the standing of board members in relation to PIDA and whistleblowing. At the bottom of page 3 and moving on to page 4, there is a reflection here of the legal advice that's been sought and the slight change that's been made to the Code of Conduct to reflect that. So I'm happy to take any questions, but I'm asking the board to approve the documents.
Any questions for Louise? Kay.
Yeah, it's around the tenure of board members, I did actually contact you because it says that board members may be reappointed but should not serve for more than 2 terms. But I'm not sure that's strictly true, actually, because obviously there is discretion with the Secretary of State for that, and so I'm not entirely sure that is accurate, and certainly not reflected in the terms and conditions that some of us were appointed on.
Yes, thank you, Kay. We did have an exchange. We're talking about page 5 of the board standing orders, and it's paragraph 3.2.1, just for members of the board, so that we can be specific about it. And as Kay has pointed out, the reference is to may be reappointed but should not serve more than 2 terms, and that's the specific reference. And in our exchange, I did say that it's not a should not be, because it's following the code of practice from the Office of Commissioner for Public Appointments. It's not a cannot be, but it's good practice so that it refreshes the members of the board. So it's not a should not, it is possible. So it's really for the board to consider whether we should change the wording there. In particular, the word should in paragraph 3.2.1.
You could put should not normally serve.
Indeed.
Does that sound reasonable? I mean, I'm just throwing out a word.
Yes.
It qualifies it.
Yeah.
Yeah. So should not normally?
That's absolutely fine. I'll change that.
Sorry,
Steve.
a bit of a technical point. I just wonder what our intent is in changing the quorum, because under the present composition of the board, it doesn't change anything, because 50% is 3. On page 3 of the report, the second bullet point at the top of the page.
Yes, thank you. There are plans, or there could be plans to increase the numbers of board members. We have a maximum, it's up to 12.
No, I understand that, but I'm trying to... Why are we changing it? Do we want the quorum to be larger?
Yes.
Okay, good.
I haven't picked that point up. It goes up to what, the quorum?
Goes up to 50%.
Okay. Okay, everyone's happy with the rest? Thank you. Are we on the minutes now? It's a bit of an odd time to do the minutes. Anyway, I wasn't at the meeting. People who were at the meeting, were they happy with the minutes? Yep, okay. Thank you. And then we've got some, for information things on here. Now, the first one is Jill, feedback on pilot of people. Is it, when it says for information, does that mean we don't discuss it? Or how do you, I should have asked you. Do you want it for discussion or not?
It's there to allow board members and others to ask questions if they want to discuss it, but it's not on the agenda with the intention that it must be discussed.
Okay. Well, firstly, Jill, the pilot of People's Voice. Do you want to say anything about him?
No, I was keen for the board to see it because I think that it's a successful piece of work for CQC. I think it very much attunes with some of the France's recommendations yesterday, which is the importance of capturing the voice of service users. And I think it shows actually how CQC was creative in terms of thinking about how it forms partnerships with representative bodies as a means of getting feedback in, and it proved to be a successful pilot and one we will definitely extend and continue further.
Sorry, Kay, then David.
Okay. Yeah, no, I'm very pleased to receive this. And it seems to me that it's, the potential going forward is that maybe this kind of thing is actually a specific intervention that we might want to use for particular issues or on a special review. So I think the learning from this could be really quite helpful going forward. It would have been useful to know, what the Patients Association and the Relative and Residents Association thought about it, because if we're working in partnership, it would have been helpful to have that feedback as well. But yes, thank you very much.
Yes, they're both renewed, so I suspect they feel quite confident about it, would be fair to say, but I could have put that in. I think they found it a very worthwhile exercise. And just to your point about thematic reviews, of course, those cross-sector groups there are really important, Kate. The groups that we work with on thematic reviews give us a huge amount of intelligence about how to form a thematic review. And again, we use their sort of expertise in that.
The only point I'd make, I think this is where we can actually say this is what we do rather than what we say, and I think the work that has been done, which predated my appointment, to form the relationship with the Patients Association and with the Relatives and Relatives Association, I think is quite exemplary, and I think goes right to the heart of actually being an open organisation and getting feedback about services. So I really do commend the work. I think on that, I saw Catherine Murphy yesterday at the lock-in. She is incredibly positive about this work. And I think it's a real signal of CQC reaching out to organisation and inviting comment back to it. I think the question it does raise is how we extend that moving forward. I think it plays right to the heart of what Francis was saying yesterday about being open. I think our challenge is how many different stimuli can we receive and how do we assemble that stimuli? And the QRP challenge is how do we turn 100,000 individual stories into intelligence which can inform those judgments which then form the decisions, which was a passage. So it's a hugely important report but I think it really is good evidence of CQC changing the way it behaves to receive information from people using services, and I commend it in that sense.
Thanks, David. Jill, thanks very much. Thank you. John, we've got the ARAC report and the REMCO report.
Chair, I think I can be very helpful for you. First of all, on the Audit and Risk Assurance Committee report, the 2 decision items have already been dealt with and earlier on in the main agenda. So the rest of this report is for information, and there's nothing I particularly wish to add to it, although I'm happy to answer any questions. There is a recommendation on a separate piece of paper, and I'm not sure whether it's been circulated or not, which is the revised terms of reference of the committee to take account of the responsibility for Healthwatch England. And basically, it's a revision, a minor revision to paragraph 5.1. But if you're happy, if the board is happy with that, then we can approve that.
Everyone happy? Okay.
The board members were asked if there were any audits that we wanted doing. And it's nice to be asked, but it felt like I could potentially be just sort of plucking them out of thin air. And so it's just a sort of thinking, if we were to, if the board was going to be involved in identifying what audits might be helpful, it may be better to have a bit more of a kind of structured process rather than sort of just saying, do you want any done? Because I just, it needs to be useful and doable, and yeah.
Well,
I mean, maybe the ARAC, you could consider that at the ARAC and come back with some suggestions.
Chair, there is a structured process. I think what was being asked was whether there were any anxieties that board members had come across that they felt were worthy of an audit investigation. It wasn't the only route by which audit investigations were pursued.
So the ARAC decides on where to do these audits?
Yeah, it has the draft audit programme reported to ARAC and it approves it, yes.
Okay.
And just on that, David, just to do this, I'd also ask that we look at what audits have been carried out, where we needed to go again because we weren't happy, and then where there were gaps, which I think is a spirit of how the resource that we've got can be targeted at those areas where we think there's the greatest risk. So that's the work going on between the officers that are supporting ARAC and ARAC to make sure that there are some criteria applied to it, which is based on our recent history of auditing, because I think we've still got areas that have not been audited, which are where we've changed the way that we operate, which is normally what audits will be pointed at. and then things that we may continue to have concerns about that we want to look at as well. So I think that planning is implicit in it, yeah.
Thank you. Anything on the REMCO?
Just a report of information.
Any questions, Steve?
David, I'm sorry, I may be speaking out of turn here, but should the board, as I think David mentioned earlier, that Deirdre has resigned, should we be appointing a chair of ARAC?
Yeah,
Or
you're
confirming,
right.
or
Yeah.
doing something anyway?
Yes, we should be. You're right, Steve. I asked John whether he would very kindly step up on an interim basis anyway. Well, after Deirdre retired, and we'll
Don't let him escape.
no, and John very kindly agreed to do that. And we'll when we've made the other appointments to the board, we'll review it then. But anyway, John, in the meantime, thank you very much.
Could I just explain that for those of you who may feel that there was some error of process in the last meeting of ARAC, which took place quite recently, or the decisions on ARAC which have taken place, which is that I am the duly appointed deputy chair of the Audit and Risk Assurance Committee, and therefore I was acting in the absence of the chair. But I thank you for your vote of confidence.
Thank you, John. The board action log, Alistair.
Nothing that I particularly want to bring to. Sorry. Nothing that I particularly want to bring to your attention, Chair. They are some actions which need some updating. Would open it up to the board members to see if they've got any concerns and queries about any of the actions.
Anyone got any queries? No. Next. Are you done?
And just to say then, there is the forward plan, but I think we will be having a refresher look at that at some point, David, in due course, and issue it in light of the priorities going forward post the plan and Francis, etc.
The meeting. We can now close the public part of the meeting and stop the recording, please. Thank you.